Welcome to the Hardy Amphitheater, Georgetown University School of Medicine. I'm Ann O'Donnell, the Division Chief for Pulmonary Critical Care and Sleep Medicine here at Georgetown. I'm really excited to be hosting this program today, and happy that you're all here. And we're climbing up the big stairs in here. We're going to have an exciting day today. As you can see, the goals of this conference are, first of all, to understand the patient's perspective, and that's our first talk, to hear from patients, a couple of patients, I think, who are representative of many of you in the audience. And then we're going to review the latest information on evaluation and treatment of bronchiectasis, optimal care for non-tuberculous mycobacterial infections, and then optimal care for other infections like Pseudomonas that patients with bronchiectasis have. And finally, at the end of the day, we're going to focus on where we are research-wise, which I'm sure many of you are interested in hearing. And we have a speaker from the FDA. We're very pleased about that. And then some speakers from the pharmaceutical industry who are in drug development for new drugs for these diseases. So appreciate everybody being here. First off, I want to thank everyone who really made this possible. First off, NTM Amy Whitman and her colleagues here, Stephen Wiskelsen. And Philip Liebman has sent his regrets. He wasn't able to make it today, but we certainly feel his presence with this group. Also, the COPD Foundation, who helps us support the Bronchiectasis Research Registry, and Mr. Craig Peppard is here from the COPD Foundation. I also want to thank my staff, who have done a fantastic job organizing this day and getting everything together. And finally, Dean Mitchell from the School of Medicine, who's allowing us to use our facilities and giving us the AV and everything free of charge. Not the usual thing here at Georgetown. So we're going to have a patient panel here right off next, and then attendees in the audience certainly welcome to join in our question and answer sessions. We have this fantastic faculty from really all over the world, many from the U.S., Dr. Ted Maris from Toronto in Canada. We have two speakers from the UK, representing England and Scotland, and Rachel Thompson from Australia. So I think everyone's really going to benefit from this fantastic lineup of speakers that we have. And here they are. We'll introduce everybody as the talks go on. So I think everyone has the program. We're going to try to stick to the timelines as best we can, so we have plenty of time for questions. And just some housekeeping things. We're not allowed to have any food or drink here in the amphitheater. We'll have buffet lunch out in the patio, or the podium as we call it. And there's restrooms all over the place. And again, I'd like to welcome first Susan from the NTMIR to give us a brief welcome.
Good morning, everyone. Welcome. You have to forgive me, I have a cheat sheet because I'm not Philip, obviously. Well, on behalf of Philip, I really want to thank everyone for being here. This is pretty incredible. It's actually too fabulous for words. But we're really excited. Of course, we want to thank Dr. O'Donnell and her team, especially Riza Peralta and Michelle Cooney, for working on the logistics for this. And special thanks to Craig Gephardt and Delia Prieto and Gretchen McCreary from COPD Foundation. We have an amazing alliance with them, which has helped really raise a lot of awareness between the connection of NTM and bronchiectasis. So thank you for that. We would like to take a moment to thank the industry supporters. We have generous education grants from INSMED and Grifols, so thank you. Additional support has been provided by Aradigm, Maxor Specialty Pharmacy, Hyman Phelps and McNamara, International Biophysics, and Electromed. Their generous support made this possible and helped us provide scholarships for patients to attend this conference. So thank you again and welcome, and we hope you enjoy it.
I'm really going to have to wing it now. So, all right. Well, again, thank you for inviting me in. It's a real honor to be here. I'm so impressed with the number of patients that I see in the audience, and obviously the world-class researchers and treaters that I see around the room. So this is a tremendous opportunity for the community and research to come together. I had a few slides that I was going to talk a little bit about because people have been asking me, why is the COPD Foundation associated with bronchiectasis and NTM? So it really goes back to probably maybe about 7 or 8 years ago. There was an NHLBI COPD Foundation workshop, and NHLBI asked us if we would be interested in helping with a registry for bronchiectasis. And so we started collaborating, and we set up an original registry, started growing that. Over the last few years, we migrated the registry from its original position back over to the COPD Foundation, a platform that we built specifically for doing research, and have been working with the Bronchiectasis Consortia, Dr. Ashton, Dr. O'Donnell, Dr. Daly, in trying to really build a meaningful research registry database to inform us about bronchiectasis and what's happening. Well, then, of course, as you all know, bronchiectasis and NTM seem to go hand in hand. And about 18 months, 2 years ago, we started talking more with NTMIR and Philip about our joint goals. And I think it was maybe 12 months ago, we collaborated on launching a web-based platform for patients to come together to communicate and to talk with each other about living with their disease and to educate each other. So one of my pitches was to ask every patient in here to join NTM Bronchiectasis or Bronchiectasis NTM. There you go, bronchntm360.org. It's a social community, but it's a social community built specifically for you if you're a patient or if you're a caregiver, to come and to share what life is like with your disorder. It's a place for new patients to come and learn. So, if you're a treating physician and you want to help patients get connected to information, again, both our organizations, COPD Foundation, NTMIR, the great place to go find information. But one of the things that we're finding now, because we've done something similar to COPD with COPD 360 Social, is we've got 30,000 individuals now with COPD on there talking about daily living with their disease. And the amount of real-world evidence that we're able to start collecting now, and now with the great computing power that we have, like IBM Watson and other sort of things like that, the insights that we're able to glean and share back with the community and share back with researchers and share back with industry partners who are trying to develop therapies for you to use in your real daily lives is invaluable. That only happens if you share your experience. So please go on and share it. It's a great place to help other people, new people. Did you have a question up there?
The website again.
Gretchen, you want to give the official?
Yes,
There's a card
in the bag that they handed out. It's from an NTM 360 Social.
.org, right? That would have been on my slide. There's extra cards out there. So again, I want to make a plea for that. The other thing I want to say is that, again, as part of our partnership and as part of our commitment to the bronchiectasis and NTM communities, we have been very actively trying to take that registry to the next level. And we have some very big goals to be able to increase the number of sites, to be able to double or triple the number of individuals who are in the registry. As you all know, going through the registry allows us to collect a lot more data, and it's that data that's really helping these researchers bring new therapies and treatments. And the best way we as a community can advance that and throw a little gas on it and get there faster is by sharing our information. And I know we're hearing this across the board with the moonshot for cancer and all of that, but the key to solving this problem is within you. It's within your bodies, it's within your genetic code, it's within the information that you can share to help the researchers get breakthroughs. And that only happens if you'll join and be an active participant. So I do want to acknowledge, we just had a very strong 3-year commitment from one of our partners, INSMED, who has agreed to help us with our goals of increasing the number of sites and increasing the number of patients. So we will be adding new sites over the coming year, and we will be focusing on particular areas of high NTM prevalence as that part. So we're hopeful that our other industry partners will see the value in that and join INSMED in supporting that. And I think that's the way that we can really accelerate our research. So if you have any questions, feel free to grab me or Gretchen during a break. And thank you so much for the opportunity. This is going to be a wonderful, wonderful conference for you. So thank you.
Thank you, Greg. I'm sorry about this.
That's okay. You would have liked it, though.
Sorry about that. So our first panel is going to be the patient's perspective. Kindly, 2 patients, Barbara Hudson and Mary Kitlowski, have agreed to discuss their experience with the diseases, and it's going to be moderated by my buddies, Dr. Greg Tino from the University of Pennsylvania, the chair of medicine at Penn Presbyterian, and Dr. Tim Axelman from Mayo Clinic in Rochester, Minnesota. So with that, we're going to get started. Sorry for this little awkward arrangement, but I think everybody will hear well.
So thank you for joining us today. What we thought we'd do was have Barbara and Mary talk a little bit about their diagnoses and their experience with their diseases. And one of the things that I asked them to talk about was really to really highlight for us the impact of their disease on their daily lives. And you know, I always remind myself, my father had pulmonary fibrosis, one of the areas of our specialty that I was interested in, and I thought I knew what pulmonary fibrosis was like, and I didn't until I saw my father struggle with all the things that he had to deal with oxygen and the impairment that he had. So I think as physicians and as providers and as other patients, it's be very, very interesting for us to hear literally on a day-to-day basis how the diseases that you have impact your life. So Barbara,
And I would just add one comment and then I'll change it over. This is a model, and if you look around the room, I think it's a model that we need to embrace. We've got patients here, we've got providers here, we've got industry partners here. This is a model that's going to be, I think, the pathway to making progress towards advances in NTM and bronchiectasis. For those of you that have either had these diagnoses or take care of individuals with diagnoses, you know how difficult and frustrating it's been. And so this is a moment for us to embrace and imagine what it would be to actually move forward, to try to advance, identify where those gaps are, and then to come up with a strategy effective for funding to meet those needs from a gap standpoint. And all of that's predicated and starts with a patient perspective, of course. And so with that, I'll turn it over to Mary or Barbara, and I'll let you go from here.
Okay. I thought I'd tell you just a little bit about my journey with NTM. I began coughing in 2012, and I broke a couple ribs and a vertebrae in my back, and I live in South Central Indiana, so I went to 4 different physicians there, 3 of them were specialists, and nobody could understand what impact it was having on my life to be able to be coughing all day long. Then I went up to a medical center in Indianapolis and saw a couple of other physicians. Again, I was coughing so hard that I could barely talk to the physician. And I remember saying to the specialist, I said, "Sir, am I going to have to learn to live with this? And I don't know how I'm going to do that, because I can't talk on the phone, I can't walk around the grocery store, I'm just coughing so much." And he responded, "Well, how the hell should I know? I don't know what's wrong with you," and went out the door. And I dissolved into tears. And then I came back to DC area where I had worked for 40 years in public health. And I saw a couple specialists here in DC. One specialist prescribed tramadol and just suggested that I suppress the cough with drugs. So after a dozen physicians, a friend of mine had gone to National Jewish, and I hadn't talked to her for about 20 years, and I called and I said, should I get on a plane and travel halfway across the country to get diagnosed? And when, people at medical centers in DC and Indiana can't diagnose me, and she said, yes, go to National Jewish. So I did. I told my local physician I was going, and he thought I was absolutely crazy, and said he would not support it. But I went, and almost as soon as I walked in the door, I was diagnosed with NTM. I fit the paradigm, and the doctors I saw prior to going to National Jewish were not incompetent. NTM just wasn't on their radar screen. I'm slender, I have bronchiectasis, I have a cough. So I guess it's the information gap that is so difficult. And even when I tell friends or I tell other physicians I have NTM, their response is, you have what? And so it's that. Now, the impact on my life is, I'm currently on 4 antibiotics. I've been on 4 antibiotics for about 18 months now. I spend about an hour a day doing home hygiene and cleaning equipment and trying to stay well. So I have some solutions to propose, but I think I'll turn it over and come back later with that.
Well, I'll share about my diagnosis. Now, I do not have NTM, and so I pretty much grew up coughing. I have a chronic cough, and I grew up in the DC area, one of the suburbs. My parents, from very early age, started taking me to different doctors, and I had various diagnoses, severe allergies, sinusitis, started taking allergy shots when I was 5, started taking different medications for allergies, but nothing was making a difference. There might be slight changes, but the cough was still there. It was a productive cough. But as a kid, being in school, and not just a little, but actually, almost like bronchospasms, if you can imagine sitting in a class, kids are so kind, right? So sitting in a classroom and, hacking my head off and just trying to suppress it as best I could. So it wasn't until I was 17 and I actually started working for my allergist that summer. And the patients would make jokes. They'd come up to the receptionist desk where I was, and I'd be coughing away. Oh, you should see a good allergist about that cough. So that precipitated, him trying, a few different drugs, and that wasn't making a difference. And finally, I had my first chest X-ray, and that's where bronchiectasis was discovered. So I was referred to a pulmonologist that was in the building, and where my allergist worked. And he kind of said, well, it's probably one of these several things. I had been checked out for cystic fibrosis when I was 12, and that came back negative, but they wanted to repeat that test. And so the preliminary diagnosis I got, at the time it was called immodal cilia syndrome. Today it's called primary ciliary dysfunction. And it's where the cilia don't vibrate properly. And so the impact, affects the lungs, the sinuses, the ear canals, reproductive organs, anywhere where there's modal cilia. So for me, the bigger impact is my sinuses and my lungs. And it's hard, because the cilia is not clearing out the dust particles and the mucus. One of the things I joke, I feel like, if I could probably power the world with the amount of mucus I feel like I produce. If we could just harness that, that might be a research idea out there for you guys. Again, as I was laying in bed yesterday, because I've been maybe with the weather, just feeling very productive. I think my body's more the 50% mucus or 80% mucus than on the water side. But, so like the challenge is, when Dr. O'Donnell said there's no water, no drinks. Well, I have to have my drink by me all the time because that's sort of like one of my tools for suppressing the cough. So I have a cough drop. That's one of my others when I'm, out and about. Tissues all the time, trying to be discreet in my coughing. So, there's definitely these impacts. And, I guess one other statement I want to make right now is, I guess even though I was diagnosed with bronchiectasis first, that was the first finding, I consider myself a PCD patient first who developed bronchiectasis because of the PCD. And I think there's a lot of patients, I think a lot of patients here probably consider themselves, say, NTM, and then, maybe bronchiectasis second. So, just kind of throwing that out there as, something to consider in terms of trying to pull patients into more of the bronchiectasis collective is, being able to talk to us, like not ignoring the other, disease that has precipitated that.
I think in the spirit of this now being a productive session, as you would say, what I would look to do and ask Barbara and maybe Mary to comment on is, what would you tell, or looking back on your experience, to the physicians that you encountered? You both had a similar experience that many of our patients have had. And then secondly, you have the ears of a number of investigators and industry partners here. What's on your wish list? And Barbara, maybe you can start.
Okay, I think for many patients, it's a long journey to diagnosis. So I would ask for healthcare providers at least it be on their radar list when somebody comes in with a cough, that some of these other diseases might be on the list. What I really want from industry is, I want a good drug.
And I know you're here. I know you're here.
I spend so much of my day either taking drugs, sterilizing equipment, or dealing with side effects of drugs. When I started the antibiotics, I didn't wear hearing aids. Now I wear hearing aids. All the antibiotics, when you take them over a long period of time, have some side effects. I'm turning brown from clofazimine. So I want good drugs. Okay, good drugs takes money. Okay, well, where do I go get money? And I think we have to educate physicians, public health officials, legislatures. We have to educate everyone. Recently, I saw on the TV, it was just a short announcement by Sokoloff Law Firm. They were doing a class action involving NTM, and my little ears just perked up. And then I Googled NTM and FDA, and I heard FDA has undertaken a massive campaign to inform doctors, public health officials, anybody that will listen to FDA about NTM infection in one small area. And what is that? Medical devices. And why this national campaign in this relatively narrow area? I welcome any national campaign on NTM, but this is directed at manufacturers and hospital administrators because surgery patients are becoming infected with NTM through a medical device. And so why is FDA undertaking this? One reason, the law. The law requires adverse events from medical devices to be reported to FDA and for FDA to take action. I didn't get NTM from a medical device. You know, CDC doesn't even know I exist. So it seems to me that the information gap can begin to be filled in if we make NTM reportable. Lyme disease is reportable. Legionnaires' disease is reportable. TB is reportable. And yet the incidence of NTM surpasses all three. So the question is, why isn't it reportable?
Well, I just, I definitely agree with that, because how can we know where diseases are happening or the prevalence if they're not being reported? And, in terms of diagnosis, the one thing, I guess, when I was 12, that was when I had the cystic fibrosis test. And I was at my pediatrician's. He had a new doctor on board who, heard me coughing and said, well, let's just run this test. And, looking back, I think that's the only doctor in my childhood who came close, but, maybe if he'd gone a step farther after that came back as negative. And, PCD is a very rare disease. There's about 1,000 confirmed cases in North America. So, although there's suspected to be as many, I think it's like 25,000 that haven't been diagnosed, because the symptoms range so much in severity. But for me, one of the things is, definitely, the more people know about these diseases, the better the research is going to be, the more money we can have to fund research. And so, even though, there's NTM, there's PCD, there's bronchiectasis. So I get the benefit of looking at bronchiectasis as a whole. The damage to the lungs, irreversible, for right now. Again, I see the benefit there. And when we've done in some of these research studies, I think there's also a benefit in tracking the individual diseases. I think there's a difference between children that are being diagnosed with PCD now. They're getting diagnosed at, infancy or at 5 years of age. And they start on different breathing treatments. They start on airway clearance techniques. And I think that makes a difference as they get older as to how the bronchiectasis presents and how they're able to deal with bronchiectasis versus maybe somebody who's being diagnosed developing bronchiectasis over 50, or over 40. You're already kind of set in your lifestyle. And, even though I've been doing these techniques for years, it's still a pain to spend this much time every day, and the impact of, even doing the airway clearance in the morning, and, then an hour later, I feel like I hadn't done anything. And, so I think looking at, some of these things that patients are dealing with when designing the research, there's one of the things that I've heard is that in PCD patients, and I think I heard this at ATS last year, in bronchiectasis patients, there doesn't seem to be as big of a change in, I think it was FEV1, one of the pulmonary functions that tends to be looked at in FDA research. If there's a change in that number, then, it's considered one of, the positive variables. But if we're finding out that that's not making a difference, or if we know that one of the disease groups within bronchiectasis is going to affect that, then, it's almost like, what's the point of doing this research with these groups all together? So I think if we could at least tag the separate disease groups as we're coordinating these studies to see what the impact is, maybe it could still be approved for the NTM group, because we've seen that it did have a positive effect in all of those patients, but the PCD or the COPD group, maybe it didn't have as positive an impact or something along those lines. And because I just want to throw out, the PCD Foundation is very leery of, they want to encourage patients to do research, but they feel like all the research patients have done that have had some potential positive showing, then gets denied. Whereas if we hadn't done the research at all, the drugs may be available because it was approved through other studies. So
just to follow up on the points that you both made in terms of the impact on a daily basis, how much time a day do you spend on, each of you, on the various aspects of your care? And the other thing I think would be helpful for some of the other patients is, are there any tricks you've learned, things that you do that have been particularly effective and that you can point out to some of the patients in the audience?
I probably spend around an hour a day, no less than an hour. And tricks I've learned, yes. I think thinking of lung hygiene like brushing my teeth, although it doesn't take me half an hour to brush my teeth, but I need to approach my lung hygiene just as a daily thing. I get up enough time in the morning to allow half an hour to put hypertonic saline in a nebulizer and just clean out my lungs, cough out everything that's there, and then other parts of my day are spent more on bronchiectasis. And the other thing I really, really try to do is avoid getting sick. I don't touch public doorknobs or, I wash my hands with good soap and water as soon as I come in the house after being outside. So I really, really try to keep from getting sick.
Excellent. And I think in the spirit of trying to stay on time, what I'd like to do is open the discussion and see if there's anyone that has questions or comments for our panelists. And maybe Dr. Tino can go up this side, I'll come up this side with the microphone. So please just raise your hand for our panelists. Thank you. And please just identify yourself and where you're from.
I'm Marcy Weiner. I'm from the Plymouth, Boston area. I'm a support group leader. My question to you is that recently we had a respiratory therapist, pulmonary therapist, come and speak to our group. He's also a full professor at Northeastern University. And he did address the cilia experience and how it really impacts us, those of us with bronchiectasis, because if the mucus becomes thin and congealed, the cilia can't move it out. I also work a little bit with a cystic fibrosis patient, teaching her some deep breathing techniques and self-percussion. And her parents have told me she is now, just for the last couple of months, on this new drug called Orkambi. And that's to help swipe off the mucus and lattices that from pneumonia that may be on the airways. And I was wondering if this is something to the researchers that could be considered for people under certain circumstances in different stages and what they may have with NTM bronchiectasis and PCD.
Thank you very much, Mary, and I will take care of that. Hopefully we'll have wipes for the microphones for everyone. For sharing that, any response, Barbara?
I didn't hear exactly given my hearing aids, but was it something better lung clearance mechanism?
Right.
And this is part of the problem.
I am particular about this, and as a group leader, I have to really coach people up. This is based on two things. Based on the cilia itself and getting the mucus either thinner or helping clear off the airways because the cilia are no longer able to do it. So this is about the drug Orkambi. And I would also say that I find deep breathing techniques to be extremely effective personally about clearing the airways every day. And I spend a lot of time on developing that and doing it every day.
Did you spell the drug for us?
Yes. Orkambi.
And I think one of the other take-homes here is there's a great enthusiasm. I can share a personal experience with patients I care for to support research projects. So we need to know, are they pertinent to the NTM patients with bronchiectasis or the PCD patients with bronchiectasis? So again, as an advocacy, I welcome your enthusiasm. This is fantastic. I would say the patients are an inspirational group because you are so supportive and so much of an advocate for your own patients. So I thank you for that. Other comments on the other side? Greg, anybody?
Price is right.
Hi, I happen to be a physician who's dealing with cystic fibrosis and PCD. So I just want to respond to one little thing that you said, which is not so little, the Orkambi. This is a newly developed drug that has been developed by research by Vertex. It's very specific for cystic fibrosis. It probably would not be expandable to other diseases because it deals with internal cellular mechanism defects of cystic fibrosis specifically. Incidentally, it's costing the range of $300,000 per year per patient, so I think it's not easy to obtain, even for the people who actually have it. And unfortunately, it's not working as well as we would have liked it. But the thing to take home from your message is that as we learn more about the genetics of these various diseases, and PCD is a prime example of where we're going with genetics, the interventions for specific genetic defects will come up over time.
Maybe time for one more question on either side, anyone? Oh, here we go. Next.
Olivia Brickley from Washington, D.C. I wondered if the panel would share with us the methods you use for disinfecting the equipment, which is very important, I think.
What I do after reading all the literature is I soak everything that I've used in soapy hot water for 10 minutes. Then I rinse it in distilled water. And then I put it in a sterilizer like you would use to sterilize baby bottles. Put it in that with a little water and I shove it in the microwave for 4 minutes. And when it comes out, the nebulizer cup or the aerobic cup is too hot to touch. So I feel like that's what I do. I don't know, there are physicians in the room that might say I've not done it correctly or that I have. That's what I do. Of course, you can't sterilize the tubing in a nebulizer, so I change the tubing once a month.
Mary, any other pearls that you'd like to share with us?
Well, for me, I do boil it in the distilled water. And we've actually been having a discussion on one of our PCD Facebook groups. And I do have a baby bottle steamer sterilizer. And I've been thinking I'm going to start using that again too.
And again, I would make a plug that this is a conversation that needs to continue for sure. And one way would be through the social network. And again, there are cards in your bags. There are additional cards available to be able to share some of these perspectives. And I think we have a last question with Dr. Tino.
Yes, my name is Gail. I'm from North Carolina, and I've had bronchiectasis probably about 15 years, and then also when I was diagnosed with NTM about 3 or 4 years ago, and so I've been through a lot of different drugs, and I had a very good pulmonary doctor. I mean, he really was good, and so he told me about a year ago, there's really nothing else he could do, and that's not a good answer, and so that's one of the things that I'm looking for. Do I need to look for another doctor, or?
Can I just say one thing along those lines? I mean, to the physicians out there, I would just like to say, there's no harm, I think, in telling a patient you don't know what's wrong. And I think that's one of the reasons that there tends to be misdiagnosis is, in my case, I found the doctors wanted to have an answer. And so what I was presenting with, they tried to fit into whatever they thought would explain those symptoms. And, it wasn't until a doctor said to my parents, I don't know, and referred them to here at Georgetown, actually, is where, some of the answers started coming. So, yeah, I just, I think that's, and not just saying, I don't know, see you later, but, I don't know, but here's, somebody else, or try this next step.
And once again, I'd like to express my appreciation to both Barbara and Mary for coming out. And to all of you representatives for NTM, for bronchiectasis, for other issues that you have. So I thank you, and I can't encourage you enough to continue to be an inspirational group for all of us, certainly on the care side of things as well. So with that, I will turn this over to Dr. O'Donnell for the next session.
So our next speaker is Dr. Alexander Quintner from Miami, who is the world's expert on scientifically evaluating quality of life from the patient conversation. So Alexander's going to give us more information on that.
First of all, I'd like to say thank you so much for inviting me, Dr. O'Donnell, NTM Foundation, and COPD Foundation. This is a perfect follow-up to hearing from people who have NTM and PCD and bronchiectasis, because my work really focuses on standardized measures of the patient's experience. So health-related quality of life, as well as symptoms. So first I want to acknowledge some people who really made the data that I'm going to share with you today possible. Kevin Winthrop's group, including Emily Henkel, Ken Olivier, who's also collected data on the NTM module, and Matthias Salate, who has really been with me from day one, helping to develop this instrument. So really, we know that NTM causes pulmonary infections, and we know so little about it. It's rare, it's poorly understood, and as we've already mentioned, very difficult to treat. So one of the challenges is identifying endpoints, outcome measures for clinical trials, so that we can develop those new medications that we were just hoping for on the wish list. It also does other things to measure health-related quality of life. We can track the progression of the disease. We can look at how the disease affects energy levels, fatigue, sleeping, physical functioning, so we can understand the disease in a better way. So this large umbrella of patient-reported outcomes is exactly that. It comes from the patient. And quality of life is one type of a patient-reported outcome. And fortunately, both the FDA and the EMA now consider standardized, well-developed patient-reported outcomes acceptable as either primary or secondary endpoints in clinical trials. And that really didn't happen until 2009. So in many ways, we're in a new era where the FDA and EMA are recognizing that the patient's perspective on benefit from a particular treatment is critically important to approving that treatment. So I think that says a lot for the importance of the patient's voice and perspective. So my bottom bullet is the aim of the study. We've been working on this for, 4 or 5 years at least, to develop an instrument for NTM symptoms, and can be used with the CFQR, which I developed in cystic fibrosis. And the CFQR is used in every major clinical trial of a new drug, including Orkambi, for cystic fibrosis. And that sort of is the pathway we're on to developing standardized, reliable measures. The CFQR was really the first in this area of chronic pulmonary diseases in CF. And we've also developed one for non-CF bronchiectasis called the QLB. So now the challenge has been to think about someone who might have non-CF bronchiectasis and NTM, or cystic fibrosis and NTM. And just for the woman who just spoke recently, we just spent 3 years at the European Union working on a new set of quality of life measures for PCD. So this work is really ongoing, it's really hard, but most importantly, it requires all of you in this room to really help it be possible. Not only the patients who are here in this room, but many of the physicians who are here today have really made this possible. So as I mentioned, the FDA and EMA now accept patient-reported outcomes, and interestingly, their definition of a treatment benefit, although we used to say in CF it's change in lung function, but in a different way, their idea of a treatment benefit is how the patient feels, functions, or survives. So when we talk about how the patient feels, that could be respiratory symptoms, that could be energy level, that could be ability to go to work or school. Survival, of course, we know is a hard endpoint. That would take years and years because fortunately we don't have that as a quick endpoint. So really when we think about the FDA definition, it's how a patient feels and functions. So all of you are really critical to that process. We start with open-ended interviews. We do focus groups. With NTM, we did several focus groups in Miami, and Dr. Salate helped me recruit those patients just to have them talk about what it's like, as we were doing this morning, what it's like to live with it. And then we reviewed the literature, what has been reported in the scientific literature. And then we developed open-ended interviews and would interview individuals with NTM for maybe an hour, hour and a half, asking them to talk about what it's like in many areas of functioning. What are their symptoms like? What is their treatment burden like, doing all these treatments each day? What is their physical functioning like, their sleep, their appetite? Basically covering all those areas of quality of life. Then after we content analyzed then we did a physician panel. Many of you in the room were on that expert panel. It was an ATS many years ago. I don't remember which city, but a little while ago. And we listened to all the NTM experts in the room who told us what they saw when their patients came for visits. We put all of those data together in terms of a content analysis and did a draft instrument, like a first set of items. Then we took those items to a new set of patients and asked them, are these relevant for you? Are these important? Do these affect your daily functioning? Are the items clear? Is the rating scale easy for you to use? And then we changed the measure according to the patient feedback. This is why it takes so long to get to this point, years and years, to get to the point where we take that draft instrument and we put it into a larger sample, which is hard to get in NTM, as we all know, for psychometric testing. We need over 100, we really need a couple hundred people. And we test then the reliability and validity of the instrument, and ultimately its sensitivity to change. Now, for my own self, importantly, I think, this is the patient's voice. If we do a good job in developing the instrument, it ends up very well reflecting that patient's experience. So we followed the FDA guidance. Whoever's here from the FDA, we followed all the requisite steps that were published in 2009. We did all these things I've just described to you. So our focus groups, you can see here 2 different focus groups, 31 people with CF. 9 pulmonologists contributed to the expert panel. Then we did open-ended interviews with 13 people with NTM. And then the cognitive testing, which is a think aloud procedure for 53 adults with NTM. And then finally, we've been pooling data from many of those physicians I talked about to look at a psychometric validation in 148. So this is just a figure, like a schematic of all the steps that we engaged in. And it is a really long process, but amazing to hear from people some of the things they experience and begin to capture that in a standardized way. So someone mentioned, for PCD, lung function is not going to be such a great outcome measure. In non-CF bronchiectasis, it's not such a great outcome measure either. But change in symptoms could be a great outcome measure. And so the idea is to take the patient's experience, standardize it, and score it in a systematic way so that we can reflect if you took a new medication or you went on hypertonic saline if you were never on it before. did it make an improvement in those symptoms? So this just shows you all the steps we follow. So these are some of the themes. I just put a few things that came down out of these. The focus groups, having a metallic taste in the mouth, fevers that come and go, difficulty sleeping. From our open-ended interviews, we gathered more information on fatigue, sensitivity to smell, feeling cold or chilled, hot flashes or sweat, especially at night. And then from the physician panel, we heard about memory loss or kind of fuzzy brain, kind of being fogged up, and some body image issues. And lots of physicians talked about side effects, which we also heard from about today. Some GI distress related to that, and then sometimes with greater disease severity, weight loss. So these are some sample items. Bothered by cold weather. Are you bothered by it? Have you experienced problems with memory? So this is the symptom module. I'm showing it to you here. So have you had problems sleeping? Have you had pain, bothered by cold weather? Have you had sensitivity to smell, to taste, bad taste in your mouth, due to sputum, experienced problems with memory? So these are the kinds of items that were distilled from this long process. So we are looking at this PROMOC alpha, that's a measure of reliability. Anything above 0.7 is excellent, and we got very good reliability on our NTM module. Now, that could seem weird because you would think some of those things don't necessarily go together, right? Memory and sensitivity to cold. But if someone is experiencing those in a cluster and someone who's having lots of NTM symptoms said, oh yes, my memory's an issue, and oh yes, I feel a lot of chills and cold, then that measure will turn out to be a reliable indicator of those symptoms. For those who had non-CF bronchiectasis, we also needed to add a few scales like body image, eating problems, and digestion. And those also have very good reliability. The QLB, which was just non-CF bronchiectasis, did not include those. But when we talked to people with NTM who also had bronchiectasis, those sorts of things came up. I wanted to show you the loadings. I mean, this is very psychometric and measurement stuff, but just to show you, these are loading very nicely. Obviously, the higher the number, these are the individual symptoms, the better it's loading on a scale. And what you see here is everything's loading pretty nicely. One that's a little questionable, if you notice the 0.37, sensitivity to smell. So as we go through our testing process and have a larger sample, I mean, I would really love to dream of 200, then we'll see whether that item holds up or whether we need to drop it. But everything here is looking very good. So I'm almost done. I just want to show you. This looks really complicated. I'm sorry. But this is kind of showing you that if you have NTM and you have bronchiectasis, you would complete the QLB, which has been developed, plus the NTM module, and some of these other issues I mentioned, digestion, body image, and eating. If you have cystic fibrosis, you would complete the CFQR, and it already has body image and eating sorts of issues related to CF, and you fill out the NTM module. And then there might even be some individuals who don't have an underlying pulmonary disease like that and have NTM, and then they would just fill out the module. So where are we going in the future? Cognitive testing has indicated the items are relevant, they're clear, very easy for people to fill out. They liked doing it, they felt like this really captured their experience. It's shown good reliability, and we need more data. And here's something else. Our next steps include psychometric testing, identification of what is a meaningful clinical change on the NTM module. And what's really exciting, I've been at this for like several years, is that Insumed has agreed to help me perform a psychometric analysis of their baseline clinical trial data that they completed a few years ago. So I'll be meeting with their biostat guy at ATS, Juan, and he and I have already talked through our analyses, which is really exciting because we can look not only at reliability, but we can see whether the symptom module converges with other important things like a 6-minute walk test, or the SGRQ, another quality of life measure, or even microbiology data. So So as your microdata goes up and down, do symptoms reflect that pattern? So I really want to thank Vincent, NTMIR, for all of the initial funding. Mostly, I really want to thank patients all across the U.S. who have helped to get us to this point. I want to acknowledge Katie Keating and her wonderful group in New York, the support group, because they actually reviewed the instrument and gave us lots of comments. And I want to thank the expert physicians who provided input and assisted along the way. Thank you.
So we have questions for Dr. Quinter or comments from our panelists? There's a question up here.
Great.
Geraldine Connors, pulmonary rehab respiratory therapist, Inova Fairfax Hospital, Falls Church, Virginia. The question I have is, Dr. Quintner, have you looked at any of the comparison of the CAT score that we have for our COPD patients and also utilize it with our ILD patients?
That's a really good question. No, I have not looked at comparisons with the CAT. I would love to. I have looked at some comparisons with the SGRQ. I mean, the QLB has been correlated strongly with the SGRQ. I don't think we've ever had an opportunity to look. This INSUMED trial will be the first one where I have SGRQ and the NTM module. So that will be my first chance to look at convergence with a different quality of life measure. But yeah, I would love to be able, convergent validity doesn't correlate with other similar quality of life measures, is one of those critical steps.
And could I ask Barbara or Mary if you can maybe respond to some of what Dr. Quintner shared with us?
Sure. As a patient, I love that we have this opportunity because I think it gives a better idea and some credence to us being able to express more how we're feeling. So it's very frustrating as a patient there are days where I don't wear the oxygen 24/7 right now, luckily, but there are days where I'll feel winded and I'll check my pulse ox, and my pulse ox is okay, but I still feel like I'm short of breath. And then there are other days where I'm moving around, I feel fine, I just happen to check my pulse ox, and I'm in the 80s. So it's just nice that on those days where my PFTs are where they normally are and all that, but I'm not feeling well, or things have been going on. It's very nice having those to kind of validate that there's still something going on.
I think that's a really important point. And these tools are really important clinically as well. And people are moving to make electronic applications of these measures so they can be used in clinic. Because it would be so awesome if you could walk into your pulmonary doc or your pulmonary center and fill out on like a little iPad. We're doing this in CF at several centers. Fill out maybe the respiratory, physical functioning, a few of the key scales, scores automatically, and then you can have a discussion with your physician. This is what I'm feeling. I felt increasing fatigue, because it will really standardize the score. Or you could say, you know what, you're so much better now that I put you on this new medication. Or I notice you're doing your airway clearance more often, and look at the improvements you're seeing. So I agree. I think it's validating for patients, but it also could be a wonderful clinical tool as you discuss treatment options and how you're doing with your clinician. And this is increasingly being done with the CFQR, and people are making now electronic applications of the QLB. And we even tested some of this in a cystic fibrosis study where we had spirometry at home, and then we had the respiratory symptom scale, and those got dialed back into the pulmonologist. So that's another really cool way that you can begin to share in real time symptoms and functioning with your physician.
One other thing I'd just like to add, I can go for a week feeling lousy, and then I have one good day, and then I forget that I felt lousy the week before. And what I like about the questionnaire is it kind of prompts, the ones I've done in the past, like in the last week or the last month, or, and that gets me thinking, whereas I might go in on a good day, the one good day I had that month, and be like, oh yeah, I'm fine, everything's great. But the questionnaire, again, it's nice that it prompts, and I think it gets more in
part of it. The FDA is very concerned about the length of the recall period. So they're very concerned if you look back over too long a period, I can't remember what I ate yesterday, pretty much. So the idea there is a shorter recall window, but it is a window over time when you're remembering your cough, your symptoms, your mucus production. And so it isn't just that very moment, it's a longer time span. Okay, good to see you.
My name is Paula Stroud. I am from Milwaukee, Wisconsin. I was diagnosed 10 years ago with NTM Bronchiectasis. I was really pretty sick for the first 2 years. I've been on usual meds, so I'm like a walking, I don't know what it is, but I've got all these antibiotics in my system. This is not necessarily directed at you, but I'm a data person by profession, and I would like to just say to everybody in this room that is somehow connected with NTM and bronchiectasis, why is there no registry? Why is there no reporting of this? And if you can, every state should have a registry to report this and find out what do we have in common that is causing this. And at the same time, it will make primary care physicians aware that this is a reportable disease. I would just like, and then you would have your data. You would have data from all over the United States. So come on, guys, let's start this.
We're going to give you some more cards.
Right. Well, I want to say, though, that we have some people here from Europe who have developed an incredible bronchiectasis registry. And I was just told that they have 6,000 data points on the QLB in it now. So I'm thinking, oh my God, I cannot wait to analyze those data. But they are doing that in Europe. They have an amazing registry. The EU has funded it, as far as I understand. And so they've gotten the funding together, and it's going to make an enormous contribution to our understanding, to testing treatments. I think a registry, this is how CF has progressed so quickly. And I've been working in CF 30 years. One of the reasons that we've made great progress, I believe, is that we developed the CF registry. I mean, first Genentech developed it, then the CF Foundation took it over. And it's an expensive enterprise, but they put the funding into it, and it has given us so many insights into what's going on in CF. So I'm a big proponent of a registry, and if you make a registry, I'm even thankful they put in my quality of life measure, because often that even gets just left off. So, yes, a registry would move the ball forward. I think you would agree, right, Greg?
Absolutely, and in lieu of, or in the absence of a formal government report, I think the EMBARC in the EU is one of the 7 we have for bronchiectasis and NTM registry here in the United States. It's funded by the COP Foundation, and we're starting to actually get some data and mine that data. And for the physicians and others in the audience, there are papers now that are publishing our experience at different centers. So I agree with you, we need more, but we're on our way.
Yeah, we don't have one in every state, but that's where they want to go. I mean, that's where locally you can.
One last question.
My name is Terry. I'm from Bluffton, South Carolina. I am a non-CF, NTM, and bronchiectasis, among other lung diseases. I have 2 drug questions. One is, we know that lack of energy is a big problem. Fatigue is lying, I can't get off the couch some days. Is 5 milligrams of Adderall safe to take? And it gives me much better quality of life. And my other question is, I was never treated with the 3 drugs for the NTM, but I was put on tobramycin for 28 days after years and years of coughing nonstop and not being able to walk 20 feet without sitting down. 28 days, my coughing went away, and I felt person.
So I'm going to refer all drug questions to the physicians. I'm actually a PhD, so I'm a behavioral scientist, so I will not touch any questions like that.
I think that those are great questions that really probably warrant additional discussion that we don't have time for at the moment. But we do have some talks coming up to address specifically treatment, and if those specific issues, whether it's with Adderall or other medication questions, I think we'll have an opportunity as the day goes on to address those. And they're hugely, hugely important, and each situation is different. So not to escape this, but to just say, let's put this on the desktop for the moment, and we'll come back to that as the day progresses. With that, thank you again, Dr. Clinton.
Thank you.